All righty, let's see if we can get this show on the road. We get everyone out of the waiting room here into the session with us. It always takes just a moment to get everyone here. How are you doing today? Hope you're having a fabulous day. As you get tuned in, if you wouldn't mind, just head over to that chat box. Make sure that your chat is going out to everyone, to all participants or everyone, not just the hosts and panelists, and give me a quick sound and video check as we get started. Always good to know whether we're broadcasting loud and clear. Plus, if you could also confirm, the slide deck is in the shared folder on our live webinars page. You can track that down. Please let me know if you can see that in that shared folder. Plus, I do know that we have a few guests here today. So again, I will share the slide deck over in the chat box so you can follow along if you wish. So I'll put that Dropbox link, kind of a mouthful over there, and we'll get started for today. Yeah. Looks and sounds good. We are off to the races. Excellent. I'm very excited for today. We are going to be talking through multiple choice question strategies. So this is one that honestly, I get this question all the time. Will, what's the best way to answer a question if I don't know the answer? And it's a good question because frankly, you'll have an idea about the concept or the content contained therein. But a lot of times it's difficult to ascertain specifically what it is they're after, or maybe you can narrow it down to two options. And between those two options, decide which one is the best option. So we will do our very best to go through some of the strategies that you can implement to get more questions correct. We will also do a bunch of practice questions together today. So I hope you enjoy that. We'll go through as many as we can. I have more queued up in the slide deck than we will be able to get to today. But through the rest of the VIP class, we'll certainly be able to get to, I think we get to every single one of those throughout the course. So be sure to tune in for all of those. So the plan today, we'll be talking through multiple choice questions and how to effectively prepare for and practice multiple choice question strategies so that on test day, it becomes very routine for you. In fact, I like to think of it as muscle memory or motor memory, that as you're going through these questions, you're able to go through a very, we'll call it succinct, logical sequence. You want to be able to go through the question in a way that is meaningful to you, that you're able to identify the key characteristics of the correct answer, and then eventually land on the correct answer. So just a quick reminder, if you haven't yet, please be sure to check out the NPTE podcast, totally free resource. You can follow that. And I do try to post to that. Like this week, I'll get to it 3 times a week. I try to do a practice question 3 times a week. Great way to stay sharp, just a little snippet, a little tidbit of content every day. I think you'll really enjoy that. Plus, if you have not already joined, be sure to join up with us in our VIP class. That's what we're experiencing here. This is the first week of our VIP class. We're getting all of the groundwork laid so that next week we will be going through the musculoskeletal system together and proceed through all the systems on the exam so that you will be 100% ready for test day. All right. So with that, let's go ahead and get started. Like I said, I've got a bunch of practice questions for you today. We'll get through as many as we can, depending on time and how everyone's doing. I will target somewhere around 60 to 90 minutes today, just depending on the questions. We'll see how many we can get to. But let's go ahead and talk about multiple choice questions. So a few key things before we even begin talking about the questions. Number one is to try to begin with a positive attitude. And so think of it this way. There is a correct answer and you can find it. There is a correct answer and you can find it. With that in mind, it makes it a lot easier to then attack the concept and the content of the question, knowing that this is something you've studied before, you're familiar with to a certain extent, even if you don't know that exact disease or that exact illness at that moment. That being said, there is a correct answer and you can find it. The thing that is difficult is on test day. I had this exact same experience, is that on test day, you feel like there are multiple correct answers to a question. And while it's true that several of the answers will have correct characteristics, there is usually something that distinguishes one above the others. And so whether that's a safety concern, whether that's an order of operations, you do this one first and then that other one, there is always something that will distinguish the correct from the incorrect. And so if you do get on a real puzzler of a question, consider that for a moment, that there is a correct answer and you can find it. So positive attitude. If you have a negative attitude, or the converse of this, it tends to lead into a spiral where you get down on yourself, say, oh, I'm not answering any of these questions correctly. So then you answer more of them incorrectly, which makes you feel worse about it. It's just a terrible direction to go into that downward spiral. Rather, I'd have you go on the upward spiral, positive attitude, dive in with a clear and level head, understanding that you can find the answer. So this is my method for attacking test questions. You'll see that this has a lot of characteristics. You have probably experienced this over all of your PT career already, but I did try to delineate the things that I like to do as a part of taking a practice question or a real question. And the real key here is that you have a clear understanding of the question. That's what these first 3 reads are. So the read the question. Read the question the first time, get a general idea of what it's looking for, find the key information, and then one last quick look to make sure that you're answering the right question. Now, perhaps the most important part of this whole process, well, I guess they're all important, so I shouldn't even say that, but a very important part is that then you should be able to formulate in your mind an answer, at least with the characteristics of the question. So if there's a question that's asking about, I don't know, let's say it's asking about difficulty with gait associated with hip flexion contractures, you would know that a hip flexion contracture is likely to limit hip extension. So one of the answer options has to have something to do with hip extension, and then you'll be able to more easily then identify the correct answer. So then the next thing is to read all of the options and try to rule in or rule out each option sequentially as you go through. One way that I had a student do this a while ago is that he would, and I really like this method, it's almost like he was keeping score of each item, meaning that each item he would give it he just made up a score. Like this item has 2 points in favor of it, but the next item had 3 points in favor of it. And you go through each of the answer options, trying to identify which one has the most points in favor of it, or compare and contrast each of the items until you find the one that is the best item or the best answer option. And that is your key or correct answer. So this is the logical method. We're going to practice this a bunch as we go through the class. Here's an example. This is off of the FSBPT's public site where they describe what the test questions will look like. So in this case, we have, after sitting at a computer station for 2 to 3 hours, an individual reports experiencing sharp, localized pain in the left arm. When asked to show the location of the pain, the individual points to the area of the insertion of the deltoid. The pain disappears when the individual stands up and walks around briefly. Which of the following interventions is most likely to correct the problem? So in this, we see the scenario. This is the information, the key information. We'll just look at the key information. We see that when the patient has been sitting for a prolonged period of time, they experience sharp localized pain in the left arm. This already tells us this is likely a position issue. And then sharp localized pain sounds like musculoskeletal pain. It doesn't sound like neuropathic pain or visceral type pain. And when asked to show the location of the pain, the individual points to the area of the insertion of the deltoid. The pain then disappears when the individual stands up and walks around. All right, so we have the pain onset with sitting. It's best or feels better alleviated with standing. Which of the following interventions should correct the problem? So we should already be able to identify, all right, we know that standing and moving changes or alleviates the pain. So it's almost like they've given us the answer. Now we need to identify that among the answer options. Isometric strengthening of the deltoid. This is not a weakness issue, so you can see that that's not particularly relevant. Lumbar extension exercises. You're like, okay, what does the lumbar spine have to do with this here? Instruction in correct postural alignment. This definitely fits the bill, and that is the correct answer. And then instruction in shoulder active range of motion exercises. You're like, well, it is the shoulders. So I think particularly it is in the general area, but it's not a really good fit. So even though this maybe would get 1 check mark for being correct, this one fits the bill in several ways. And so this would, again, be the winner if you were to compare all of the answer options. So that's the anatomy of the multiple choice question, the scenario, the stem, key, the options, all of that. There are always 4 distinct options, and the options they will never include a none of the above or some of the above. It will be 4 distinct concrete options. Now, it could be written in a negatively worded way. And I'll show you some examples of that where it says least likely or is not present or except. Those types of things could easily show up on the test. In this case, we see a very distinct stem. Now, and the other thing, which of the following interventions, there's almost always a noun here. Which of the following which of the following interventions is best? And that will also guide you to say, all right, I need to make sure that whatever my answer option is, that it fits this word. Which of the following interventions is most likely to correct the problem? So, and this is just delineating what we talked about: scenario, stem, options, and a key. So let us go through another example here. So I'm going to roll out a poll. I will be quiet while you respond to this question, and then we'll talk about it together. I'll give you about a minute. Ready, set, and go. All right, just a few more moments. All right, and time. So on this one, a patient has used crutches with partial weight-bearing toe-touch gait for the past 3 months. And so I like to envision, what does that look like? Partial weight-bearing, toe-touch gait. So they're walking on their toes for the past 3 months. When progressed to full weight-bearing, the patient is unable to demonstrate a heel-toe gait sequence with the involved extremity. So what does that mean? Well, it means they're striking their toe first rather than their heel and then their toe. Which of the following disorders is the most likely origin of the gait abnormality? So again, keywords, we have partial weight-bearing toe touch gait for 3 months, so a prolonged period of time again, and is unable to go heel toe. Which of the following disorders is most likely to cause, or most likely origin of the gait abnormality? Plantar fasciitis, first we'll consider that. The characteristics of plantar fasciitis would be the first 2 steps of the morning are the most painful, or the first steps in the morning are most painful. That is not described here, so doesn't really fit the bill. Fibular or peroneal nerve palsy, so that would be a significant weakness with as you recall, the deep peroneal nerve is the ankle dorsiflexors. So in this case, we don't see anything that's describing a weakness issue. I mean, possibly, if you're striking your toe first, it means you're not lifting up your foot. We'll put one small check mark in favor of it, but it's like, okay, kind of fits, maybe. Heel cord tightness. Now, this does fit the bill. The tightness coincides with the prolonged period of time, especially considering the position. So position and time giving us definitely a much more plausible scenario that they are just a little bit tight. And then finally, hammer toe seems to be irrelevant because we don't see anything describing the foot. That would not preclude a patient from striking their heel first. And so in this case, we see that heel cord tightness is indeed the correct answer. And you can see that plantar fasciitis and fibular peroneal nerve palsy don't particularly fit the bill, as well as heel cord tightness does, associated with that prolonged period of time. Excellent. So that's kind of fun to go through these questions, these examples together. I do have some more questions. We'll go through a few more questions here in just a minute, but I wanted to talk about some of the other characteristics that you need to do as you go through. We've already talked about this a little bit, but as you go through each question, do your very best to formulate in your mind what the correct answer will look like, and then keep score of which answer option looks to be or appears to have the best or most likely correct. So a lot of times you are just comparing and contrasting. Other things to consider would be they love mix and match questions. Like one I saw was about the APGAR test. It said the APGAR test grades appearance and pulse in addition to what other characteristics? And it's grimace, activity, and respiration. but it mixed up a few other things like blood pressure and I can't even remember what the other things were mixed in, but they mixed and matched like 3 or 4 different things among all the answer options. So just remember, if an answer option is partially incorrect, then it's totally incorrect. That would be an example of the mix and match style questions. And in fact, I've got some examples of those coming up here in a little bit as well. Other things to consider on the test, you can expect to see some image and video questions. Image and video questions. So the key thing with image and video questions is that you want to see the answer options first in order to narrow your focus on the image or video. So it won't do you as much good if you stare at the video and say, I don't know what it's showing me. Rather, go to the answer options. Once you've seen the answer options, then it can help you to narrow your focus so you can evaluate the video a little bit more easily. So in this, the same thing for the image too. Rather, in this case, like what's being shown here, if I just had the image with the arrow here, you may or may not know that that is a Hill-Sachs lesion, which occurs after an anterior glenohumeral joint dislocation. This lesion, it's like a dent on the humeral head. So let's say you didn't know anything about that. All you see is there's an arrow pointing to the humerus. Well, then you go to the answer options, you read the question and the options, and it says, this injury was most likely incurred while doing what, or with what injury. And then you go back, look at the answer options, and it'll include dislocation. It could also include like, I don't know, muscular strain or something that maybe is less relevant. And then you can go back and say, well, that makes a lot of sense that if this has slipped out of the humeral socket, out of the glenohumeral socket, that it could dent on the acromion process, or on the side, not even the acromion process, on the side of the glenoid. So as it dents against that, you can get what's called a Hill-Sachs lesion, as you recall, Hill-Sachs lesion. In any case, that's an example of how you wouldn't evaluate the image until you knew what you were looking for or looking at. So read the question and the answers first before evaluating the image. All right, so what happens if you don't know the answer? Let's say they give you a totally left field question, like one that someone told me about the other day. It was like Sever's disease. What is Sever's disease? So just by raise of hands, how many of you have ever heard of how many of you have never heard of Sever's disease? What in the world is Sever's disease? Well, Sever's disease is a childhood illness where basically it's the growth plate of the calcaneus starts to slip. And so you start to get a slippage or almost like a breakage of the calcaneus. And so as you do so, it starts to slip off. It's a lot like slipped capital femoral epiphysis. So skiffy in the hip, it's Sever's disease is in the heel. It's the same type of thing, a childhood illness where you have the calcaneus falling apart. In any case, let's say you had no idea what Sever's disease is. So number one, just remember, there is no penalty for guessing. So the question was about Sever's disease. Let's say there's no penalty for guessing. Okay, great. So that takes some of the pressure off. And then the next thing to do is to look. There's a couple of things you can do. You can look for what body system is being identified in the question. All right, is it musculo, is it neuro? That again helps narrow your focus. Try to identify, is this an intervention, differential diagnosis question? One thing that can be helpful, don't get me wrong, this is not going to solve all your troubles, but pay close. In the case you have no idea what the answer is, look at the lengthiest answer option, the one with the most words in it. A lot of times that has more detail in it and can at least give you a clue as to what the correct answer is. It's not always the case. And like when I write my questions, I try to create what's called parallel construction in the answer items so that I don't have one item that's way longer than the others, but just pay close attention to the lengthiest answer option. Try to eliminate any outliers, things that are totally irrelevant. Like if the question was about Sever's disease and you had no idea what Sever's disease is, but then it mentioned hip, the epiphyseal hip or the epiphysis of the hip slipping, you'd say, well, I know that's not Sever's disease. That's slipped capital femoral epiphysis. You can eliminate that because you do know something about that one. So as best you can, eliminate what you do know and then narrow down to 50-50, again, dramatically increasing your odds of getting that question correct. So again, I wish I wish I had a way to tell you, and it's always so funny because it's asked in such sincerity. I'll get a student who will say, Will, I really need to be able to answer the questions that I don't know the answer to correctly. And unfortunately, they write the questions, so it's hard to guess it. So like when I was first, this would have been 10 years ago now, when I first started writing practice questions for PT final exam, as I was getting it started up, I'd have my wife, who's not a PT, she's a Hispanic linguistics major, has no medical training, just has all language training, but was very good at tests. My wife, she would look at my questions, and 9 times out of 10, she would guess the answer. And it would frustrate me, like, but she said, well, Will, you're writing it so I can guess it. I can eliminate outliers. I can see things that are implausible. And so then over the course of a couple of years, I like to say I honed my skills. And now my wife can't guess any of the questions that I write because you have to have at least some knowledge about the content contained therein. And well, I shouldn't say she can't guess any of them, but it's certainly not 9 out of 10 now. But she uses the same process of being able to analyze my questions to say, all right, is what appears to be the correct one or what appears to not be the correct one. So there you go. There are some keys to help you answer correctly the questions that you don't know the answer to. Other things to consider would be, certainly if you can narrow down to 50-50, try to consider what would the most reasonable therapist in the whole world, what would they say is the correct answer here? So this is what they call like a third party or out of body type consideration. Don't ask what you would do. Ask what your most revered PT friend would do. So let's say Susan B. O'Sullivan, the author of Physical Rehabilitation. Let's say that she was standing right here. What would be the most reasonable thing for Susan B. O'Sullivan to do? Or fill in the blank of your most reasonable therapist and consider what would they do? Or another way to look at that would be to say, what would the textbook say about this case? Again, it's difficult if you don't know anything about the condition, but it can help at least to narrow your focus. Other things to consider would be skipping steps. Don't skip steps. So another very, very tricky question I saw was about someone with a rotator cuff injury, and they come into the clinic and what would you do first? And one of the answer options was Codman pendulum exercises, which is a great intervention, by the way, great intervention for rotator cuff repairs. So it's totally passive traction. It's great. Another answer option was to get a detailed, or not even detailed history. It was get a clear understanding of the prior level of function. And in a way, it feels like there's 2 correct answers there, because you would absolutely get an idea of the prior level of function, but you would also initiate Codman pendulum exercises. So which one is it? Well, you go in order. You have to always start with your history and review of systems before proceeding on to physical exam, and then do that before you proceed on to intervention. It always goes in this order, that you have to have a clear understanding of what you are up against before then making your decisions about your examination, your physical exam, and then continuing on from there to be able to identify a correct intervention. So that could be one that can be very vexing, but look for that on practice tests, that a lot of times there's an order that you would do this one first because it's all about collecting data, and you do this next because that's an intervention. So again, I've seen some fairly tricky questions about that, and I don't want you to ever be tricked by that. And then certainly what we'll do as a part of the class is understanding the content. This is where you do your very best to bump into questions and content that you don't know yet and try to put it into your own words. And this is where, like when I was doing OCS exam, the orthopedic certification specialty exam a few years ago, this is what I did. For every practice question that I thought was tricky or I didn't know the answer to, I'd make a flashcard about it. And I continued that process until I had many dozens and dozens of flashcards about things I didn't know or didn't know well enough to answer a question about. And it was fabulous review because it was very targeted and specific. And then the other thing is that it forced me to create the flashcard or the little bullet point item of the thing I didn't know. And so even that exercise was very helpful in getting things to stick long term. And I've got stuff about that in the VIP class. I have a whole 4-part series about how to get information to stick long term. And I would highly recommend that that be one of the goals that you get done this weekend before we begin our official musculoskeletal stuff next week. All right, so question comes across, is psychological testing always last? What about assessing general awareness like the Rancho Los Amigos test? Yeah, so the reason I put psych testing at the very end is because usually psych testing, we're talking about Waddell's signs, signs of malingering, Hoover's test, anything that would be we'll say inorganic or non-organic causes. Then you start to see if there is a somatoform disorder like conversion disorder, something that doesn't make sense as far as we'll say for an organic cause. Psychological testing, that would be more related to personality and malingering. Whereas in the case that you're describing, the Rancho Los Amigos levels of cognitive functioning, that fits more into neurotesting. The levels of cognitive functioning, that's a rating where you give them based on, are they automatic and appropriate? Are they confused and agitated? You get a general, really, you'd probably get that done during your review of systems and detailed history, start to get an idea of what the level of cognitive functioning is, and then would polish that up with neurotesting and special testing. That, again, would give you a clear understanding of where their their level, classification of functioning following a traumatic brain injury. That would not fit into psych testing. That would fit more into neurological testing. It's a great question, by the way. No one's ever asked it quite like that. And you're exactly right, because like after a traumatic brain injury or after a stroke or even after a concussion, which is a traumatic brain injury, any of those items, you are assessing their neurological status, but it's not necessarily a personality or faking it type test, the malingering tests. Rather, you're looking for actual observable signs that would help you classify the patient. All right, we've already talked about most of these tips, but if all else fails, put your best guess. Answer options are randomized, so there is no particular pattern to the answer options. Don't worry about patterns too much. And then don't change your answer. Don't change your answer. How many of you have ever changed your answer from the correct one to the incorrect one because you got in your own head? So don't do that. Only change your answer in the case that you like misread the question, or there's something that you totally missed, and now that you see it, you can clearly identify the correct answer. So don't change your answer unless you need to. So how's that for advice there? All right, let us go. Let's do this. I'm going to go through a few of these text practice questions. Then we're going to jump over to the FSBPT site, and I'll show you what their demo exam looks like. And so you can see legit what the exact image and video questions will be like on the test. And then that'll get us here to the finish line today. All right, so some strategies, just other quick little strategies as we get to our practice questions. If you're a very fast test taker, meaning that you complete the test very, very quickly, be cautious. There is a problem with that. You could read too quickly and overlook information. I have done this many times. I'm sure you've all had this same experience where you read through the question, you selected the answer, and then you went back and read it. You're like, oh, it said this. Why wasn't I more careful in my reading? So you have the risk of overlooking items, but the big advantage of being a fast test taker is you don't have to worry about fatigue as bad, because you are only in there for 3 or 4 hours instead of 5 hours. Or in the case you have double time, like I've had students that say that they have double time accommodations, so they're approved for 10 hours of testing. But the trouble is that at hour 9, their brain is just fried, that they just can't look at any more questions that day. So therefore, it doesn't always help to use every single second. Rather, just go at your pace. Find your pace, your rhythm, where you can be careful and still complete it under the allotted time, and go with that as your rhythm. And that's what you'll do with practice. So every 1 to 2 weeks, and I talked about this on Tuesday, but every 1 to 2 weeks, I do recommend taking a practice test just to get the feel of what it feels like to sit in the chair for 3 or 4 hours, to understand what it's like to look through, to be concentrated for that long. And then your final practice exam, I would recommend taking somewhere around a week or so out from test day. So 1 to 2 weeks. The reason I say that is because you need to have adequate time to review it before test day. You don't want to take a practice test, like as a silly example, you don't want to take a practice test the night before the NPTE. That will just stress you out and you won't have any time to learn anything from it. It will do you no good. So rather give yourself a little bit of time, adequate time to go through that content. All right, practice questions. Let's dive into a couple of questions here. All right, so I'm going to roll out a poll box again. So you'll see a poll jump up in front of you. If you don't mind, I'll give you about a minute to respond to this. I will be quiet while you do so. Ready, set, and go. All right, just another moment. All right, this is a question, kind of a mix and match style question. When compared to upper extremity exercise test results, so when compared to upper extremity exercise test results, lower extremity exercise typically results in what? So lower extremity exercise typically results in what? Well, we know that the upper extremity has a greater hemodynamic response. So upper extremity has a greater than the lower extremity as far as hemodynamic response. So this question is all about the lower extremity, though. The lower extremity will result in a lesser hemodynamic response. And so therefore, the correct answer here is that you will have a lesser heart rate and a lesser blood pressure response as a result of lower extremity exercise. Your maximal oxygen uptake is greatly increased. This is the VO2. As an example, I like to say this, that, if I had you run a mile on your hands or run a mile on your legs, which one could you do easier? Well, clearly running on your legs are just built for that. There's greater muscle mass. There's more type 1 slow twitch muscle fibers, more mitochondria. Your VO2 is increased, but you will have a lesser heart rate response. That doesn't mean no response. It just means a lesser heart rate and blood pressure response. So this is an example of making sure you know the content both forward and backward, because they could ask it to you either way. All right, so that's kind of a tricky one, right? We know that the upper extremity will have a greater heart rate and blood pressure response. So this is a mix and match. We know that it's lesser. So we see that while this is correct and this is correct, the lesser blood pressure response and the increased maximal oxygen uptake, that is correct. You will not have a greater heart rate response. And then you can go through and do that same exercise through these other answer options. So the key take-home point is that the upper extremity has a greater blood pressure, and heart rate response. That's because it's more stressful on the system. There's more sympathetic activity. As you activate the upper extremities, you get tired faster. And so your body tries to accommodate all of that excess fatigue, excess oxygen demand, you could say. And so by comparison, the lower extremity has a lesser blood pressure and heart rate response, meaning there is still a response, but it's just to a lesser degree as compared to the upper. And that's maybe the most important word in this whole question, is when compared, when you're comparing the two. Good. All right, next question here. Let's see. There's a question coming over about the PT final exam practice exams. So for the PT final exam practice exams, they do include rationales for all of them. There's 1,200 questions in there. So we've got rationales and resources for all of those. They are not included in the crash course. They are an additional purchase to the crash course, but all the exams are included in our other products. So the VIP class, the independence class, the premium class, all of those would include access to the the practice exams. All right, your next question here. We're going to roll this one out. Give you a minute on this. I will be quiet while you respond. Ready, set, and go. All right, just another moment. Just another moment. So the reason I give you about a minute is that on test day, you should be 72 seconds or less on every item. So just over a minute is your maximum amount. So if we target about 1 minute, that gives you a good pace to stay on track to finish the exam in time. A patient who has suffered a traumatic blow to the posterior knee begins to exhibit signs of tibial nerve dysfunction. All right, so tibial nerve dysfunction. Which of the following impairments will most likely be present with a tibial nerve injury at the level of the popliteal fossa? All right, so blow, tibial nerve. This also, everything lines up to be, this is about the tibial nerve. Which of the following impairments will be most likely to be present with a tibial nerve injury at the level of the popliteal fossa? All right, so as you consider the tibial nerve, you know that it comes down, it's part of the sciatic bundle until just above the knee, then it separates out into the common peroneal and the tibial nerve. And so at the level of the knee, that's where, at the level of knee, that's where you have the full separation of tibial nerve from the common peroneal nerve. And so therefore, what we're looking for tibial nerve-wise is, we know the tibial nerve innervates the plantar flexors. So we know that the correct answer would have to have the plantar flexion in it. So weakness in plantar flexion would be key. And then the other question, or the other part of this mix and match style, is if you're looking for dorsiflexion versus plantar flexion, the other thing you're looking at is where the sensory loss would be. So we know that weakness with dorsiflexion, that's the deep peroneal nerve, as well as the sensation of the dorsal surface of the foot, also related to the peroneal nerve, the superficial peroneal nerve, and I guess down by the toes, that's the deep peroneal nerve. But weakness with plantar flexion, that is the tibial nerve, so that is correct. However, loss of sensation on the dorsal surface, that is incorrect. And then we get down to dorsiflexion, that's the deep peroneal nerve, again, incorrect. So we got incorrect, incorrect, partially correct. And then finally, the last answer option is tibial nerve is plantar flexion and the plantar surface of the heel. That's where the tibial nerve is, that's where that terminal branch is headed to. Excellent. All right. So the next question, we'll go ahead and queue this up. This question comes across the chat box saying, is there a discount for the practice exams? Yeah. So if you have a previous purchase, we can help you out with a discount on the practice exams. Or if you're upgrading a class, we can also help you with a discount there, just depending on, anyway, if you have a previous purchase, we can help you out in some cases, but generally speaking, there's not a general discount for it. It's already at its discounted student price. All right, question comes across. If they had a blow to their posterior knee, what would make it have weak dorsiflexion and sensation to the dorsal surface? Meaning, is there anything that changes the level of the popliteal fossa? At the popliteal fossa, you know that it is distinct from the common peroneal nerve. If the injury was, say, above the popliteal fossa, it is possible that you could have damage. You'd have to call it the sciatic nerve at that point. Damage to the sciatic nerve as it's separating out into its two branches. So if instead of being at the popliteal fossa, so that's popliteal fossa. If it was, say, above the popliteal fossa, then you'd be into the sciatic nerve proper. And in that case, with that sciatic nerve, you would be injuring the tibial plus the common peroneal, because that is what makes up the sciatic nerve. So it would change things if this question were to say above the knee, then you'd have to, it would also have to say it was an injury to the sciatic nerve, and then you'd have to have totally different answer options, because then it would affect both plantar flexion and dorsiflexion. So it's a good what if question. So I like the way you're thinking of that. All right, next question here. We'll roll this one out, give you a little mobilization question, give you about a minute on this. I'll be quiet while you respond. Ready, set, and go. Right, just another moment. All right, this question, a patient is noted to have limited great toe extension during the terminal stance phase of gait. So we know that during terminal stance, you look, so this is our Birdman taking a walk. During terminal stance phase of gait, you have the great toe, oh dear, this poor fellow. But the great toe is an extension, and so we have limited great toe extension during the terminal stance phase of gait. In order to increase the first MTP joint extension, which joint mobilization would be most appropriate? So we need a joint mobilization. It's going to increase first MTP joint, so the first knuckle of your foot, I guess you could say. So we want it to extend. Well, we know that the metatarsals have a convex end, and the phalanx, the proximal and distal phalanx of the toe, are concave. And so this is applying the concave rule, meaning that you have to have a glide in the same direction as the roll. So therefore, the correct answer here is the dorsal gliding. So dorsal gliding of the proximal phalanx. As you do so, you see that concavity. As you dorsally glide that is going to assist with extension of the great toe. So if you're like me, and you always get confused about the foot and the hand, this is something that helps me. You can tell me if it helps you or not. So everyone make a nice fist for me. Show your nice fist. You can see pretty easily your knuckles. Those are the heads of the metacarpals. Then you know that those metacarpals are nice rounded convex heads. As you move the fingers on them, those fingers, the phalanges, the proximal phalanges, are concave, moving on those nice rounded metacarpal heads. So therefore, for the fingers, you apply the concave rule. Same thing in the foot. The foot is almost identical in that regard, that as you have the metatarsal heads, your phalanges, your toes, are moving on the metatarsal heads the same way. So if you ever get confused, just make a nice fist and say, oh, the metacarpal heads are all convex, so therefore the fingers must be concave. I don't know. That's something that helped me as I was trying to figure this all out. The other thing, we'll talk about the thumb a little bit more in class, but the thumb is a saddle joint. And if you can just remember, if you were to give me a high five, let's say you were just giving me a high five in the screen right now, and just say, okay, high five. Or another way to look at it is put your hand flat on the table, moving the thumb away from the other fingers on the same plane. That's flexion and extension. So using those same words, flexion and extension, it follows the same concave rule for flexion and extension of the fingers. So as long as you can identify flexion and extension of the thumb, you will follow the same flexion and extension guideline for the fingers. Ab and adduction, that's where you move the thumb away from the other fingers in the opposite plane. Then it applies the convex rule. So that's how the thumb is a saddle joint. And again, the way to remember that is that the fingers are flexing and extending as a concave joint. And so when the thumb is flexing and extending, so the thumb is moving away from the other fingers in the same plane, that's flexion and extension, you apply the concave rule. So isn't that nice? They name it all the same thing so you can keep it all straight. All right, let's go ahead and move over to, if you want to find where it is I'm going. So what I'll do is I'm going to stop this share. I'm going to switch screens here for a moment. So stand by. Let's see if I can get this to work. All right, stand by. I'm going to get this rocking and rolling. So you're going to see me share a different screen here in a moment. All right. I share this one. So you should be able to see now the exam demonstration, or the NPTE demonstration exam. So this is on the FSBPT's website. Can someone just confirm for a moment that you can see what it is I'm talking about? Do you see the FSBPT website with the NPTE demonstration exam? Excellent. All right, so now we're going to go, the easiest way to find this is just Google search NPTE demo exam. So now we go to start the demo exam. We're going to queue this up. Okay, this is like what you'll experience on test day. So test day looks like this. Let's go. Test day. You're in the Prometric Test Center. You have to read the terms and conditions. So they give you the same terms and conditions. The NPT is, you can't share it. You cannot copy it. You can't transmit it or steal it in any way. So you go through all this, and this is just like what you'll experience on test day. Now we get to the exact actual questions. Now, I guess more demo about what to do. But the next, when we come into here, this demo exam has two sections. The first section is for the PTA exam. And so just as an FYI, these first couple we will look at are PTA questions, but they demonstrate the same point. So on this one, and the next section is PT. So we're going to go ahead and skip ahead to these picture questions. So if you can see this, again, those of you on desktop should have an easier time seeing this, but if you can see what it is we're talking about here. So we see an image of a patient's hip and knee with some markings on the image showing us what would ostensibly be the Q angle, the difference between the tibial line and the femoral line. And so that difference or distinction between the two, that angle is what we're looking at, the tibiofemoral angle. So before we analyze this picture too much more, we need to look at what the question is saying. If angle 1 in the photograph is greater than 20, which of the following complications is the patient most likely to develop? So we have patellofemoral tracking disorder, genu recurvatum, lateral collateral ligament sprain, and medial meniscal lesion. So we come back up to our image. We see the image. Okay, so angle 1 is being shown here. If it's greater than 20, meaning there is a more significant angle between these two, between the tibia and the not the fibula, tibia and the femur, what is likely to occur? So now we will go through each of the answer options and decide which one feels best. Patellofemoral tracking disorder, this pretty clearly fits the bill. Okay, so if the angle is off, that means the patella can't track superior and inferior very well. Genu recurvatum doesn't really fit. That's more of a sagittal plane issue where you're going, or sorry, more of a, yeah, the sagittal plane. Yeah, it's a sagittal plane issue where you're going forward or back inside that. Yeah, sagittal, coronal, transverse. Yeah, frontal plane. Yeah, it's the sagittal plane. It's totally the sagittal plane. I have to think through the planes every time. Genu recurvatum would be in a different plane. It doesn't really fit here. LCL ligament sprain. So if we look at the LCL, the greater this angle is, actually, the more you will, greater the angle is, the more slack you'll put on the LCL, and the more tightness you'll put on the MCL. So it would rather be the medial collateral ligament. And finally, medial meniscal lesion. Well, again, it's gapping or opening the space on the medial meniscus. So it's most likely to cause problems to the lateral meniscus, not the medial meniscus, giving us the correct answer of patellofemoral tracking disorder. All right, so that's an image question where you go through the question and answers before analyzing the image. Now we'll go through a video question Again, just can you confirm, someone, just one or two of you, confirm you can see the video that is now playing on this screen? Can you see that? Someone confirm? Okay, excellent. The exercise in the video would be most appropriate for a patient who has which of the following gait deviations? So before we analyze the video, we see that we're looking for gait deviations. So contralateral pelvic drop during stance, forward trunk lean during stance, circumduction during swing, and excessive lateral rotation during swing. All right, so the exercise in the video would be most appropriate for a patient who has which of the following gait deviations? And then we see these gait deviations. All right, so first of all, as we look at this picture, what did you call this exercise? A lot of you have seen this in clinic. What did you call this exercise? You call it lateral stepping with bands, right? Or a lot of people call this monster walking, although monster walking usually has a forward component, but the same idea that you have the abduction resistance. So in this case, you can see that it is an abduction resistance exercise. So which of these gait deviations is related to the abductors? In fact, I'll give you that question. I'll give you a moment to respond to that. So I'll give you the poll box to jump in front of. So I'll just scroll up and down a time or two so you can see the question again. I guess you can see everything there. So the exercise in the video would be most appropriate for a patient who has which of the following gait deviations? Well, the only one that's related to the abductors is that contralateral pelvic drop during stance. The forward trunk lean is related to weak hip flexors, specifically the rectus femoris. Circumduction, that's usually due to a tight or stiff knee, so limited knee range of motion. That doesn't really fit. Excessive lateral rotation during the swing phase, that would be in the case you don't have good hip flexors. You compensate with the hip adductors. So this is for hip adduction, like adductor magnus. Again, doesn't fit the bill for our abduction issue here. So those are the abductors. Excellent. All right, let's move on to we'll do two more examples of this. We're going to finish the section. Now we're going to go into the PT section. And I do recommend you take a moment and come and do all of these items just as a practice. It's kind of a fun exercise. Let's go to the image item. And on test day, it will be randomized. You won't be able to identify, like, there's a lot of things that will be randomized, but you will have all of your image and video questions will also be randomized throughout. So this maybe is not representative in that regard, but because 11 and 12 are both image and video. But in any case, we see a picture showing patient's shoulder in range A and range B. And so just reading the question, while abducting the shoulder, the patient in the photograph denies pain while moving through A, but reports increased pain as moving into range B. Which of the following disorders is most likely present? AC joint, subacromial bursitis, infraspinatus, and partial tear of supraspinatus. So we come back up to our image. Now we evaluate it. We see that we have denies pain in A. Okay, so we deny pain in A, but reports increasing pain severity in range B. All right, so we have range B is worse than range A. So range A, this is what's called well, I should ask you this. What special test is being shown in this image? What special test is being shown in this image? You recall the name of this special test. This is the painful arc test, where you look at range, the mid-range, and then the top range. If there's pain in the mid-range, that tells you that you have subacromial bursitis. So in range A, that would indicate subacromial bursitis, some type of rotator cuff dysfunction. In range B, this is what indicates AC joint pathology. And so again, armed with that knowledge, you can say, even if you didn't know that, you could say that range A, this is all about mid-range abduction, where the supraspinatus and infraspinatus are working the most, and where you'd get subacromial bursitis. So there's no pain in A, but more pain in B. That's where you get that adduction coming across, and it's smashing the AC joint. So therefore, the correct answer here is the acromioclavicular joint if you have pain in B and not A. Excellent. And then the final question, so this one's a little trickier. It'll take us a moment to go through. And the nice part now is that you and I, we have time to go through this, but on test day, you'll be limited in time. So that's why you try to get this pace all set. Try to work on your pace so you go quickly. Patient reports a decrease in pain when the therapist performs the test in the video. Based on this result, which exercise should the therapist recommend? So we have decrease in pain with this test, whatever it is. What exercise should you recommend? So now we go to these answer options, and you just have to visualize what these look like. With a patient in standing position and elbow in 90, the patient performs shoulder abduction while maintaining the back against the wall. We call these wall angels, where you keep the shoulder blades back against the wall and you perform abduction. So this is a coordination type exercise. With the patient in standing, the patient laterally rotates using a resistance band, so external rotation with resistance band. The patient in prone, with patient in prone, the shoulder in 90, the patient lifts the arm towards the ceiling, thumb pointed up. This is a strengthening exercise for the middle trapezius. And then with the patient in standing, the patient elevates the arm overhead in the scapular plane. So just raising the arm overhead. So now we go to our video. So we see that the patient reports a decrease in pain when the therapist does what they're doing. So if you were to, let's say you had no idea this is the scapular assistance test, what could you identify in this video? Well, you'd identify that the therapist is stabilizing the shoulder and assisting with upward rotation. Right? So something, whatever we do, has to have something to do with upward rotation. So if we have a decrease in pain when the therapist is helping, that means they would have an increase in pain if the therapist was not helping. And so that's what option 4 is doing this movement without help. And so that would worsen the pain. That's the problem here, is they can't do that. So we take that out. The middle, so option 3 was about the middle trapezius. That's the prone T, where you're horizontally abducting the arms. Again, that's hitting middle trap, which is not associated with upward rotation. Rather, the upper trap and lower trap are, so we can take that one out. This one is kind of the outlier, external rotation with the resistance band. It's a rotator cuff, but this is not a rotator cuff. This is a scapula issue, leaving us only with wall angels as the correct answer. This is for scapular dyskinesia. You're trying to improve the coordination of the scapulae as they go into upward and downward rotation. So that's a tricky one. That one, yeah, I'll admit, the first time I saw that one, like, I have no idea what that special test is. But one of those things where you say, all right, what are they doing? Well, and I had to visualize each of these answer options, say, all right, what does that look like? And how would that help? And just logically go through each one, giving it either a thumbs up or thumbs down, literally, depending on what it's likely to be doing. Question, what is the answer for this last question? The correct answer is the wall angels. So with the patient in standing position, elbow 90, they're abducting the arm. And so as they're doing that, they're working on scapular coordination and upward rotation. So option 1 is the correct answer. These other options are incorrect. Wall angels is the best exercise here. This is called the scapular assistance test. And the way you perform the scapular assistance test is you have the patient do it solo, do it by themselves first. And they say, ouch, I don't like that. Then you do it again with the therapist helping, and they say, oh, that feels better. That is a positive scapular assistance test. Good. All right. So the question that comes across is, I missed it. Where on the FSBPT website do we find these questions? So the easiest way is to just Google search for NPTE, FSBPT demo exam. But the more precise location is on, if you go to the exam candidate handbook. So if you go to the exam candidates, you see the NPTE, prepare for the exam under the NPTE demo exam. NPTE demo exam. Good. Very good. All right. Let's do one or two more questions. You got time for one or two more questions? I know it's always interesting to go through bunches of questions. All right, next one we'll do. So you should be able to see, I should have switched now to a PowerPoint slideshow question. Can someone just confirm you see the PowerPoint slideshow question about angina pectoris? Excellent. All right, I will be quiet while you answer this question. I'll give you about a minute to do so. Ready, set, and go. All right, just a few more moments. All right, and time. So a patient that is experiencing angina pectoris, so chest pain, from myocardial ischemia will experience exacerbated symptoms with fill in the blank. And so we have angina pectoris. They're going to have exacerbated or worsened symptoms with what? Well, they're going to experience exacerbated symptoms with increased exercise workload. Rather, the ingestion of antacids is unlikely to affect it. I guess in the case of females with heart attack, sometimes this can have a decrease effect, but certainly not an exacerbation effect. Then nitroglycerin use, so nitroglycerin, that's meant to reduce angina pectoris. So again, if the key word here is exacerbated or worsened, it would certainly not be worsened with antacids, nitroglycerin use. Palpation of the chest wall, this would only be in the case of a pericarditis. Pericarditis, where you have an actual inflammatory reaction of the chest wall, it could be worsened with palpation, but we don't have any indication that there's pericarditis. All we have is myocardial ischemia, leading us to the correct answer of increased exercise workload. Very good. All right. Let's go ahead and jump to, let's do, like I say, just maybe one, maybe two more. All right. Let us go to this one. 147. All right. Roll out this question, give you about a minute on this. Ready, set, and go. All right, just a few more moments. All righty. During examination by a physical therapist, a 6-month-old patient, so pediatric patient, presents with weakness of elbow flexion and forearm supination of the right arm. So they can't flex their arm and they can't supinate their arm. So, as you consider what would cause that, it'd be loss of, say, musculocutaneous nerve or the biceps brachii, the elbow flexors are lost. And so therefore, I guess before we get to therefore what, in addition, the involved upper extremities position in scapular depression adduction, so scapula is down, adducted, and internally rotated. So they have internal rotation. Which of the following conditions is most likely present? So as you consider elbow extended, pronated, internally rotated, you say to yourself, oh, that's starting to sound a lot like Erb's palsy. Now, claw hand, you can see that claw hand would not be particularly associated with it. It would be intrinsics of the hand, usually related to Klumpke's palsy. That would be C8 and T1 issues. But in this case, we see Erb's palsy, damage to the upper brachial plexus, C5 and C6, losing the musculocutaneous nerve, which would lose the biceps. Let's see, Klumpke's paralysis, the loss of the intrinsic muscles of the hand. Again, that would be claw hand. And then finally, thoracic outlet syndrome. Again, less likely to be present just with the depression internal rotation. Rather, the biggest thing with TOS is that you'll have loss of radial artery pulse, loss of the radial pulse. So it would be exacerbated by shoulder or neck movement. And then biggest thing is that you'd have some type of paresthesia or neurological component there as well. So therefore, it leaves us with the correct answer of Erb's palsy, also known as the waiter's tip deformity or waiter's tip position, where the arm is internally rotated with the wrist flexed instead of extended. You've lost C5 and C6. Excellent, excellent. All right, let's see. Let's go ahead and do one more. And we'll finish up with questions you may have. All right, this question, give you about a minute on this. Ready, set, and go. All right, just another moment. All right. When evaluating micturition and continence, which of the following statements best represents normal bladder functioning? So we have which one best represents normal bladder functioning. So micturition, this is about urination. Normal bladder functioning. Parasympathetic, this is a mix and match style question. You see parasympathetic innervation mediates voiding via the hypogastric nerve, parasympathetic via the pudendal nerve, sympathetic via the hypogastric, and sympathetic via the pudendal. So we see mix and match between hypogastric, pudendal, sympathetic, parasympathetic. So I guess one of the ways that I remember this is that when you have to go to the bathroom, when you have a very full bladder, that is the sympathetic nervous system that is holding on to it. Think of it this way, that the reason you get so excited to get to the bathroom in time is because the sympathetic nervous system has amped up and ramped everything up. The parasympathetic nervous system, the rest and digest, that's what you feel after you've peed. That's that calm, call it that calm satisfaction of having urinated and emptied your bladder. So then it's a question of which nerve is involved here. So the parasympathetic nervous system via the pudendal nerve is what voids or opens the bladder, you could say. So there's two things that have to happen to urinate. You have to have contraction of the detrusor muscle. So activate the detrusor muscle. That's number one. And number two, you have to relax the sphincters holding in the urine. So you contract the detrusor and open up the sphincters. That's what just opens the flow. That's what the parasympathetic nervous system does. So the easy way to remember this is the triple P. In order to pee, you have to have the parasympathetic nervous system via the pudendal nerve. Triple P. Then the other one is the sympathetic nervous system via the hypogastric nerve. That's what doesn't mediate voiding. It mediates bladder filling, mediates filling the sympathetic nervous system via the hypogastric nerve. So sympathetic is part of the filling, and then voiding is the parasympathetic nervous system. And again, think of it this way: as you consider the case of autonomic dysreflexia, someone who has autonomic dysreflexia with a T6 or above spinal cord injury, one of the primary causes of autonomic dysreflexia is sympathetic nervous system activation from a full bladder. So that bladder has filled, activating the sympathetic nervous system, and then they can't activate parasympathetic to void it because of the dysreflexia. And so I guess that's one of the associations I make in my mind, is that the sympathetic nervous system is associated with bladder filling, parasympathetic with bladder voiding. So to P, parasympathetic via pudendal, the triple P. All right, so let's talk now about the assignment going forward for this week. So those of you who are part of the VIP class, next week is our musculoskeletal week. So you've got a couple of things you've got to get done before then. So between now and the end of the musculoskeletal section, so between now and the end of next week, ideally you will have reviewed and completed as best you could all the study strategy modules. So that's what these modules, they're on the course dashboard. They talk about long-term memory, about appropriate study patterns, all the things that you probably already know, but to fine-tune your study skills. And then review and complete as best you can the musculoskeletal section of the workbook. So this is all meant to be a targeted approach. It's not busy work. Please don't ever do it as busy work, but target your weakest areas first. The other thing you'll do during musculoskeletal week is I have musculoskeletal recordings broken down by major joint. So we've got the upper extremity, the lower extremity, the shoulder has its own, the spine. You'll go through each of those modules. I've got an interventions section. Go through each of those modules as best you can between now and the end of next week. So what's today? Today, as we're recording this, Thursday. So by the end of the following week, that'll be our musculoskeletal week. You will have completed all that. And then just as you know, it's always good to take a practice exam as a good start, baseline performance. So if you do have a PEAT, great time to take that, or you can take one of our practice exams to get a good baseline performance. And then the workbook is available to you in PDF or .doc file. But I also have some printed copies. If you need a printed copy, just send me an email and I can get you a printed version. I really like the spiral binding of printed versions so that you can open it, lay flat, stay organized as you study. Again, it should never, ever be busy work. It should just be work that work with a goal, I guess you could say. So that's the goal here. What questions do you have as we come to a conclusion here today? Tell me, what questions do you have about either the course, about any of the content we talked about today? Rondeep says, can anyone get the PDF of the workbook? Yeah, as a part of the VIP class, it's included at no extra cost. I do have availability if you want to purchase it by itself, and you can send me a message about that via email and I can help you out there. Sonia says, is it better to do the modules, the video stuff first, or the workbook first? I like them both. So you'll hate my answer is that you'll kind of work on them simultaneously. So maybe do a couple of the videos and then do a couple of the sections of the workbook and just pair them up nicely. I would not make it concrete saying, oh, you must complete videos first before continuing with the workbook. The workbook is just an active way to stay engaged and study. So the only thing we're really working towards is you passing the test. So just trying to get the content to stick long-term. But I would recommend each day to go over some video and then go over some workbook content. Excellent. Very good question, by the way. Very good question. All right. What other questions do you have? So the VIP class, our general schedule will go twice a week. We'll go through practice questions together, lots of practice questions, a lot like what we did today. Going through the content in tricky questions, try to get you really have lots of practice so that when you get to test day, you will have taken many, many practice questions and have a good idea, not only of the content, but of the of the process of answering those questions. Excellent. All right. Well, let's see. So other questions we've got. A question comes across, is it possible to purchase just the musculoskeletal portion? Right now, I don't have that available. I mean, those of you maybe watching the recording in the future, you can always check back, but right now it comes as a complete package. Another question comes across, what is the crash course? The crash course is a 3-week super condensed version of the cardiomuscular neuro systems. It's like cramming of just the key components of those big 3 systems. And that's done right before the test. And you can find out all the details of that at ptfinalexam.com. There are discounts if you have groups of 5 or more that want to get together. And so from cohorts, so if you're a part of a university cohort, we can get you a discount there. Another question comes across, what's the difference between the VIP class and the premium class? So the VIP class, we meet twice a week. We go through every system in detail. You have the full video library, the additional recordings, crash course, exams, everything. The premium course is you only meet once a week and you get most of the content done, we'll say in a coached way. You still meet once a week, but you go through most of the content on an individual basis rather than in a class basis. And that's run by other instructors. The VIP class is run by me, yours truly, specifically. So let's see. Shelby says, are the questions for the quizzes on the exam simulator the same as those on the exams? They are pulled from the same bank. Yes, we have the full bank of questions divided into exams, but if you pull quizzes, they are pulling from all of the question bank there. There's not a separate question bank for quizzes. Ashlyn says, do you recommend purchasing the full report from a previous NPTE attempt? Sometimes. So in the case of a previous failed NPTE attempt, if your score was less than 580, it usually helps to get that score report. If your score was greater than 580, it puts you just right there at the threshold, meaning you're like 10 questions away from passing. And I bet you dollars to donuts that before let's say you scored a 585, and before you purchased the report, I were to ask you, well, where did you feel weak on? You'd say, oh, I felt weak on musculo. I bet you dollars to donuts that your report would show exactly what you already knew. So that's why for a very close score, usually doesn't give you a lot of information to buy the report. So I generally recommend that you only purchase that if you're 580 or below. Let's see. Sonia says, if we do the PEAT, will there be an answer key after we take the test? Yes. So that's exactly right. Sonia says, is the PEAT timed? Yes, it is timed. But if I'm not mistaken, you can set your time if you have accommodations or if you have normal time, just the regular time. So if I'm not mistaken, you can. Anna says, do we need additional textbooks and what do you recommend? So as a part of the course, you get access to all of our study guide or video modules. So you won't need a lot of textbook, like everyday textbook content. However, it is nice to have the textbooks available, and I have those listed on my website, the ones that are most likely to be tested from. So that's physical rehabilitation, McGee, Dutton, Kisner, all those. And I have, like I say, I have all those listed on the resources page of our site. But yeah, generally speaking, between the written content I've got for you plus the videos, that's pretty solid for most people. Is the PEAT 5 hours just like the real test? Yes, the standard time is 5 hours. Cheyenne says, if we're taking the NPT in October, will there be another VIP course offered in August? Yes. So the VIP course, you get 9 months of access. And so if, say, you were targeting the October exam, and to get the most bang for your buck, you'd sign up for the July round. You'd be able to more casually go through the July course. And then we'd start up again in August for the October series. And in a sense, you'd get 2 for the price of 1 it behooves you to sign up earlier than later because you're able to use the content for a lengthier period of time and not be quite as rushed on the VIP class. But yes, we do repeat this quarterly. So at this very moment, as we're doing this session, we're targeting the July exam, but we would start up our October exam in August, our January exam in November, and our April exam in February, if that makes any sense. We start about 10 weeks before every test day. Excellent. All right. Well, with that, we'll bring it to a conclusion today. Thank you so much for your participation. I hope this was helpful to you going through these practice questions. Those of you in my VIP class, I'll catch you all next week. We'll go through musculo next week. So you've got your homework lined out. If you do have any questions, feel free to reach out on that private Telegram group for our VIPs. Great place to get questions answered. In the meantime, have a fabulous weekend. Will Crane fist pumps all around, and I will catch you all next week. Thanks. Have a great day.